Assalamu alaikum doctor. In this video I am discussing a video station that is about intestinal obstructions, and the task may be come with vomiting, abdominal pain and abdominal distensions. The patient present with tachycardia and shock features. So that is the surgical abdomen intestinal obstructions. How can we do that? First of all, so it is a case of intestinal obstruction where you find distension of the abdomen, vomiting, that is greenish vomiting. It is green color vomiting, then we tell that. And what are the differential diagnoses we can keep? Volvulus, intestinal malrotation, sepsis, intersusception, gastroenteritis, paralytic ileus, toxic megacolon. These are so volvulus, intestinal malrotation, sepsis, toxic megacolon, intersusception. These are. What are the history we ask? Onset, course and duration, what increase and what decrease. Any vomiting, its amount, color, is it green, and the content of the vomiters. So vomiting, amount of the vomiting, what are the content of vomiting? It is green in color. Then constipation, recurrent jelly stool, so intermittent nausea relieved by vomiting, abdominal pain, colic, abdominal distension, fecal incontinency, fever, weight loss, affection of the sleep and activity, consciousness of the child, number of the going to toilet, feeding habits, any tears, and dry mouth, bruises, hepatosplenomegaly, lymphadenopathy, shortness of breath, yellowish discoloration of the sclera. So mainly OCD, increase, decrease. Then there is vomiting. Vomiting is very important. Amount of vomiting, color of vomiting, it is green. Content of the vomiting. Then about the abdominal pain, abdominal distensions, nausea, about the poo, about constipations or bleeding in the stool. Then family history. Then we can ask about fever, weight loss, affection of the sleep, consciousness of the child, number of going to toilet, feeding habit, any tears, dry mouth, then any hepatosplenomegaly, lymphadenopathy, shortness of breath, and yellowish discoloration of the sclera. Then examination ABCD, vitals very important, hydration status and evidence of shock, capillary refill time, skin turgor, shrunken eyes, we do the RBS level. Abdominal examination for rigidity, ascites, organomegaly, and any palpable mass for rectal impactions. Palpate of the focal tenderness, including guarding and rebound tenderness on palpations. Then percussion may give a tympanic sound, and auscultation may reveal there is tinkling bowel sounds, and both signs characteristic of bowel obstructions. Rectal examination for empty rectum or gush of gases. So ABCD vitals we do. Abdomen examination we do, and the child is present or shock or not, we need to exclude. And rectal examinations. Now about investigation, full blood count showing leukocytosis, ESR CRP, full blood count showing leukocytosis, ESR CRP, liver function test, albumin lactate will be high. Urine electrolyte we do because hyponatremia, hypokalemia, and metabolic alkalosis in case of proximal obstruction, and acidosis in case of strangulation. Urine analysis, then X-ray of the abdomen, multiple air fluid level we can find, ultrasound or CT of the abdomen, air or barium enema. So investigation, full blood count, ESR CRP. We are doing X-ray of the abdomen, electrolyte, urine electrolyte, serum creatinine, ultrasound of the abdomen, CT if needed, and X-ray of the abdomen. So these are the investigation we do. Now what about the management of intestinal obstruction? Management is that admission, NPO, nothing per oral, IV fluid, resuscitation if shocked, and urinary cath. NG tube to control the vomiting initially. So first we settle the child. Like admit child, nothing per oral, IV fluid. If any electrolyte imbalance, shock, we will correct this. Electrolyte imbalance, we will correct this. We give NG tube to control vomiting initially, and antiemetic we can give, total parenteral nutrition. Then treatment, if needed, surgery, then surgeon will be involved. These are the treatment. Talk with the consultant. So what is the, they are telling that NG tube to control vomiting initially. Venting gastrostomy is in a fit patient with gastroduodenal or jejunal obstruction, and persistent vomiting may relieve symptoms. Total parenteral nutrition because it is only appropriate for a very small group of patients with a longer prognosis. After some patient, specialist advice. Stop medication reducing peristalsis like cyclizine, hyoscine, 5-HT3 antagonist, and amitriptyline. Laxative are often needed. Treatment of paralytic ileus, use a prokinetic antiemetic. Analgesia up to fentanyl patch, barium or air enema. Treatment of partial obstruction. Partial obstruction, how can we treat? With low fiber diet. If failed, so surgical correction and dexamethasone parenterally for 4 to 7 days. Treatment of complete obstruction is decompression by surgical or endoscopic evacuations or stent if colon cancer. Surgical intervention is indicated in patient with suspicion of intestinal ischemia, then a cause that requires surgical correction such as strangulated hernia or obstructing tumor. Patient failed to improve with conservative measures. What is the complication of intestinal obstructions? Bowel ischemia, bowel perforations, peritonitis, severe intravascular fluid depletion resulting acute kidney injury and other end organ injury. So bowel perforation, bowel ischemia, acute kidney injury, bowel ischemia, bowel perforation, peritonitis, acute kidney injury. So you understand intestinal obstruction, that is abdominal distension, vomiting, presentation, bilious vomiting. DDR, volvulus, intestinal obstruction, volvulus, strangulated, any hernia, then it can be any intersusceptions, paralytic ileus, any sepsis. And OCD, increase, decrease, and vomiting descriptions, stool description will ask any hepatosplenomegaly bruises. An examination, ABCD vitals, abdomen examination, rectum examinations. Investigation, full blood count, yes or CRP, then urea electrolyte, creatinine. We do the X-ray of the abdomen and ultrasound of the abdomen. If CT needed, we do. And treatment is fast. We will give manage the child, stable the child. Like the child ABCD vitals we check and we give NPO, IV fluid we give. If shock, then shock correction occur. If electrolyte imbalance, correction occur, and NG tube we give, and then we will conservative treatment. If not improve, we go the surgery. Bile ischemia, perforation, peritonitis, sepsis, acute kidney injury is the complications. Thank you.